So good evening, one and all. I am Dr. Sanket Nivale, representing Medical Affairs at Emcure Pharmaceuticals. And it's my pleasure to welcome each and every one of you for this another episode of No Thrombosis workshop series in acute ischemic stroke. And it's my pleasure to introduce our course director, Dr. N.R. Ichaporia, sir. Sir is a director neurology at Sahyadri Hospital, Pune. He has started his first neuro ICU and neuro intensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India. More than 300 public lectures and workshops on stroke. Member of the Indian Stroke Association and the organizing president of StrokeCon 2012, the organizing president of ISA Stroke School. He is the ex-president of the Society of Neurosciences, Pune, and an ex-president of the Maharashtra Academy of Neurology and founder of the Pune Stroke Group. He is the principal investigator for multinational stroke trials like PERFORM, BG12, cortical venous thrombosis, BrainsCARE, Interact2. Recently, he's been awarded as a health icon by the Times of India Group. Sir, we welcome you for the event.
Thank you.
Our moderator for today is Dr. Rajshekhar Reddy, sir. Sir is a director, Max Institute of Neurosciences, Max Super Speciality Hospital, Saket, New Delhi. He's a part of Fortis Hospital Ranbaxy Group Company, Noida, since Jan 2005 to 2006 May. 23 publications in national and international journals, participated as a speaker at multiple national and international platforms. Sir, we welcome you for the event. Our guest moderator for today is Dr. Professor Manmohan Mendinata, sir. Sir is an ex-director, professor, Department of Neurology, Govind Ballabh Pant Institute of Postgraduate Medical Education and Research, New Delhi. He's an ex-director, professor, and HOD, Department of Neurology, Janakpuri Super Speciality Hospital, New Delhi. In terms of publications, he has more than 351 Google Scholar and citations of 55,983, 179 PubMed Index paper publications in high-impact national and international journals, such as Lancet, Neuroepidemiology, Neurology, Stroke, etc. And more than 60 book chapters in world-renowned neurology books. Editor-in-Chief, International Journal of Epilepsy since 2014 to 2019. Published 3 Cochrane reviews. Book published, Puzzling Cases in Stroke, with 3,000 copies subscribed, and second edition is in progress. 1,500 MCQs for postgraduate and postdoctoral entrants on NEET platform. Pattern. Sir, we welcome you for the event.
Thank you so much.
Thank you, sir. Our first speaker today would be Dr. Divya Goyal. Ma'am is a senior consultant and HOD neurology at SSB Heart and Multispeciality Hospital, Faridabad. She has 10 plus publications in national and international journals, neurophysiology training experience in epilepsy monitoring unit and sleep lab, expertise in IV thrombolysis, administration of botulinum toxin, and plasmapheresis. Ma'am, we welcome you for the event. We have a second speaker, Dr. Sanjay Kumar Khaminwar, sir. Sir is an associate professor and HOD of Department of Neurology, Chalmida Anand Rao Institute of Medical Sciences, Karimnagar. He is a consultant at Lotus Neuro Hospital at Karimnagar. He has thrombolized more than 150 patients till now. Sir, we welcome you for the event. With this, now I'll hand over the session to our course director, Sir Ichaporia, sir. Over to you, sir.
Thank you very much for this wonderful program. This is the third in the session in this program, and we've had some absolutely breathtaking cases. And along with Rajshekhar, and I'm sure he'll agree that we've had some wonderful discussions. Awesome. And, it has gone on into the night, and, really we've had to stop talking. So I'm sure this session is also going to be the same. And I welcome both the speakers. And we are very happy that so many young people are taking part in thrombolysis and presenting their cases, and we are having such fruitful discussions. So now I hand over to Dr. Divya Goel to present her first case. Dr. Rajshekhar, would you like to say something?
No, sir, I completely agree. And it's been very, very enriching experience for all of us, the last 3 sessions that we've had. And I think the people who presented earlier had such subtle nuances of these cases that we discussed, and the difficult problems that they brought up and we discussed. I think it was an all-round learning experience for everybody. I think everybody just gained so much. And I'm sure that this session today will also be the same. So, I think that's with that you could ask them to go ahead and start the session.
Yeah, and we welcome our dear friend, Dr. Manmohan Mendinata. He's our guest moderator for today. And I'm sure he will enjoy today's session, and he will give his inputs as usual and make it more enlivening. Dr. Mendinata, would you like to say something?
Thank you so much. This is my first chance to be in this program, and I'm quite excited, and I'm honored to be invited by Dr. Sanket, his team, by Dr. Nasli, and to see good friends like Rajshekhar Reddy and the Goel. And I'm very sure, learning what has happened in the last 3 sessions, I'm very geared up to learn more and contribute whatever best I can. So with these words, I'll wish all the very best to the speaker, as well as the participants, and to all of us to update our knowledge further. Dr. Nasli, please.
Yeah, Dr. Divya, could you go ahead, please?
Yes, sir. Sir, first of all, I would like to thank all the faculty and Dr. Sanket for this opportunity. So just sharing my screen. So I would like to start with a video showing the basics of this case. This case presented to us within 4.5 hours of the onset of symptoms. First, I'd like to show you the symptom video. This patient presented in an altered state. Basically, he was confused, and this was a sudden onset confusion. We were trying to ask the patients the name of certain things. For an example, I handed him over a coin, and I was asking, what is this? So as you can see that he neither could tell the name, nor he could tell the use of the object.
Second cheese try करना, ठीक है? दोबारा से लिखो.
So the second object that we used were the bunch of keys. Again, neither he could name it nor he could tell the use.
लगाते हैं इसको किसी चीज में?
नहीं लगाते हैं.
हाँ, क्या करते हैं?
लगाते हैं.
किसमें लगाते हैं?
So entirely confused, could not express himself.
ये बताओ कोई बात नहीं.
The third object coming up.
अभी बताया था ना आपने क्या चीज़ है? हाँ, शाबाश बताइए. Pen.
So finally, after a great effort, he could name that it is a pen, but again could not name the complex objects like the cap of the pen. So entirely confused. So this was the introductory patient of the video of the patient, that he could not name the objects, he couldn't tell the use of the objects. So onset of symptoms was about actually 4 hours and 20 minutes when he presented to us to be appropriate. This was a sudden onset confusion. For the other aspects, his fluency, reading and writing, all the things were disturbed. There was a partially affected comprehension for the complex sentences particularly. In the next video, I'll be showing when we were testing the parietal lobe. I asked him to draw a clock, and as we can see that he repeatedly wrote 13 on the paper instead of all the numbers in the clock.
और क्या लिखोगे इसमें? Arrow बनाओ पापा. Arrow.
So we asked him to draw basically the handles of the watch, and this is what he did. So the parietal capacity was also affected. Herein, we asked him to copy the clock as I had drawn a clock before him. So this is what he did. He wrote the number 9 and then 10. And then 10s are coming repeatedly.
कोई बात नहीं, आराम से.
So 112 is coming. So even his copying capacity was affected at that moment of time.
2, 2, नीचे 2, yes, 3.
So once he was dictated the numbers, he could write them.
6, Papa, 6. Yes.
But
7,
definitely he had the tendency to
और
repeat.
8 सेंटर में. Exact. 8 Papa, 8.
कोई बात नहीं,
7 के बाद 8 बनाओ. 8. Yes, very good. ठीक.
अब 10:10 2 एरो लगाने हैं ना.
So when we asked him to make the handles of the clock,
पहले सेंटर में हाँ करो.
again what he could do was,
Very good. और दूसरी सुई कहाँ गई?
10 पे.
so copying was a bit better than the spontaneous drawing of the clock. So we conducted his MRI, and this is the diffusion weighted image which showed a sylvian infarct in the left side, the dominant side, and it was already 4 hours and 20 minutes until we conducted this MRI and all. So he was thrombolized with injection tenectase, 0.2 milligram per kg dose. So what happened was, in the initial phase, hemorrhagic transformation of the infarct occurred. Unluckily, I do not have that CT showing the hemorrhagic conversion of the infarct. It was a relatively late thrombolysis, and this hemorrhagic conversion occurred 2 days post thrombolysis. The patient was doing okay. His vitals were fine, but his confusion persisted even after thrombolysis till the day we discharged him on about the 4th day. So after 2 weeks, we followed up the patient, and this was the video that I recorded on follow-up. So this is follow-up at 2 weeks.
और जी आपका नाम क्या है?
राकेश चौहान.
ठीक है, मैं कुछ चीज़ें दिखाऊंगी आपको, वो बतानी क्या क्या हैं. पहले ये क्या चीज़ है?
पेन.
ठीक है. ये क्या चीज़ है?
चश्मा.
ठीक है. और ये क्या चीज़ है?
मग है, गिलास है.
ठीक है. अब एक पेपर पे मुझे घड़ी बना के दिखाएंगे, उसमें आपको 11:10 का टाइम दिखाना है.
So the naming of the objects was perfect and fluent.
दोबारा बना लो, कोई बात नहीं.
Then we tested his
क्या बात है, बड़ा बोला.
clock drawing ability. So as we can see that spontaneous clock drawing was improved. This improvement just occurred within a span of 2 weeks of thrombolysis, which was relatively late.
11:10.
ये तो हो गया 11.
बहुत ही बढ़िया.
So this was particularly an interesting case of acute ischemic stroke who presented a bit late to the hospital. There was a left dominant side sylvian fissure infarct, and we could thrombolize him relatively on time. And definitely we could see a late improvement, but there was a total recovery from the patient's side, considering his fluency, reading, writing ability, his memorizing ability all into account. So this was the case that I wanted to discuss. Open for discussion now. Thank you.
Thank you, Dr. Divya. Dr. Mendinata, would you like to comment?
Yeah, Divya, can you bring back? There must be a lot of residents and junior faculty.
Yes, sir.
Because the moment I saw his face, static face, not the video, I made the diagnosis.
Okay, sir.
You just show it again, I'll tell you.
Yes, sure, sure, sir.
Just the first slide and static, not the video. Just first photograph. Yeah.
Yes, sir.
Yes. Now, there must be my neurology colleagues as well as residents here, maybe DM and DNB students. If you look at this face, this gives a very surprised, frustrated look. Look at the furrows on the forehead. And obviously today is a stroke, so one can imagine it's going to be a case of stroke. So seeing that, it appeared this is a expressive aphasia. Because if it was Wernicke's aphasia, person are usually jovial, not worried, no insight. While here is that insight is preserved and person is frustrated. When you are giving the coin for naming and also action like agnosia, he was feeling frustrated. So clinical sense, I'm saying, very important to know, in addition to therapeutic, diagnostic, a quick by the residents, second year or third year neurology residents and faculty, that this is anterior aphasia and most probably Broca's aphasia, where all those 6 items, what we say for Broca's aphasia, have to be tested quickly. The time may be short, whether MRI or CT protocol, whatever institute follows, has to be done, and you have done a wonderful job by doing within 4.5 to or little more. And I will discuss later about the therapeutics. Let my other colleagues also come in and pitch in and give their opinion. But this was very clear. This is left MCA infarct, most probably, or left MCA stroke, if not, or left MCA territory stroke, or whatever. Most probably ischemic, and it is in the anterior part of the MCA.
Yes.
That is what I wanted to say. And there was some executive function also affected, and naming, as well as the agnosia was there, agnosia component was there. Those, yeah, please, you can stop, and then we'll come back to therapeutics later.
Sure, sir.
Thank you, Divya. Nice case.
Thank you, sir.
Yeah, what an astute observation, Dr. Manmohan. This is a true
Thank you so much, sir.
Thank
you, sir. Thank you, sir. Thank you so much.
You know, those furrows on the forehead and the slight facial droop, this is an experienced clinician talking. I mean, nobody else can.
Thank you so much.
Too good.
Thank you so much.
Yeah. Dr. Divya, you did all these tests afterwards, or you did it when he came?
Sir, actually, we didn't have that much of time. So we did thrombolyze him, and after thrombolizing, I carried out all the tests.
Correct. So you know, message to everyone that fine, you do all these tests, but you have to do a quick clinical examination.
Yes,
you can't do a detailed clinical examination.
Yes, sir.
You have to do the NIHSS, and quickly you have to decide.
Yes, sir.
So, you know, just looking at the face and just looking at the facial droop and just asking 1 or 2 questions, that's enough.
Yeah. Sir, actually, in this case, we performed a CT only. And because of the sudden onset confusion, because we were already short of time, we injected him with tenectase, and all these procedures that the MRI carried out and the examination carried out, this was post-traumatic.
If you've done the CT?
Sir, just for the, actually, ours also, hospital is also a teaching institute. So just for the students to see, this is a proper case of transcortical motor aphasia. His repetition was actually spared in this case. So we just wanted to make the difference for the students, that just see the infarct and just see the case clinically also and correlate.
So that was done later?
Yes, sir, that was done later.
What about the angio?
Sir, MR angio, brain and neck vessels, both was performed.
CT angio you did at the beginning?
No, sir, not CT angio in the beginning.
Rajshekar? Sound.
You are muted, Rajshekar.
Sorry about that, sir. So I think that's very good. You made a good case here, and I think that you diagnosed very appropriately that there is an aphasia. So one of the learnings from this is that even if the NIHS is not very high, there are certain exceptions to the NIHSs. So aphasia is one of them. Apart from that, hemianopia and hemi-neglect can also be criteria for thrombolysis. So this is a place where I think that also should be a learning point for people, that in the absence of weakness, language disturbances merit thrombolysis if the patient comes in the window period. But in all such cases, I would, like sir was saying, that we would like to do a CT angio right at outset. if you've got a plain CT, which is normal, you're planning to do thrombolysis, you want to make sure that there isn't any major vessel occluded there. And then you go ahead and, of course, thrombolize. And then, of course, you've done all these, the clinical examination was very detailed and very good learning. Important to always say that right-handed person comes with such and such. That's another thing we often, while presenting a case, and the residents need to be taught that, whether it is left or right-handed, that is important that they need to understand non-dominant, cross-dyphasias, etc., etc. So I think this was a good learning case, but important to remember, exceptions to NIHS rule is also a learning point for such a case. And the CT angio must be done at outside. And most of the time, if it's normal, it's fine, but at least we know where we stand. Okay? So that's an important thing. So, so you can go ahead and see.
Dr. Manmohan.
After this, sorry.
One aspect I want to ask Divya, and again, for the learning for each of us, all of us, and inter-institution, like between Max Saket, BLK Max, or Dr. Nasli Institute or Dr. Divya Institute. When did the tenective place? Was it when CT was being done, and CT has been done there itself, in that, or in back to ER, and there you gave the tenective place? Very important to know.
Yes, sir. This is one thing, one advantage of tenectase, that we are thrombolizing the patient in the CT itself. We are bringing the staff with a full-blown syringe, and which was not possible with LT-place. We are doing tenectase as a bolus dose in the CT itself. The CT picture comes in the CT room itself. We thrombolize.
Wonderful. Why I wanted, because thrombolysis is picking up in our country, and that's the biggest advantage with tenective place. Not only bolus, and without any other paraphernalia around, we can give it if there are no very strong contraindication. And as my colleagues Nasli and Rajshekhar said, that CT angio, I think, takes almost same time as CT scan of the head these days. So I think that's one of the necessity. You were on the borderline, otherwise you would have thought of doing CTP also.
Yes.
But CTP, because you were on the borderline. And final, when it's ending, then I'll make some comment about the duration of thrombolysis. I have in my mind, and I have told my colleagues, like the time has been increased from 3 hours to 4.5 hours. I have something else in mind, which I read during first profession in Boyd pathology. I'll quote that, but later with the permission of the course director.
Yes. So then you thrombolize the patient in the CT scan.
Yes, sir.
And what happened?
Nothing, sir. His vitals were checked. They were all okay. The patient was still confused. We brought him out. And after conducting his clinical examination, after that thing, then we conducted an MRI just for the sake of it, just to look at the infarct size. So,
so pure academic MRI.
Yes, sir. Pure academic.
Pure academic. Okay. And then you said that there was a hemorrhagic conversion.
Yes, sir.
There was was it a parenchymal hemorrhage, or was there a drop in the NIHSS, or there was no drop, or what was the clinical situation?
Sir, there was no drop in the NIHSS, just that when we perform a CT 24 hours after thrombolysis to see whether there is any hemorrhagic transformation or not, it revealed a bit of hemorrhagic transformation on the first day itself. And then, but there was no drop in the GCS. The patient was totally conscious.
So then that is irrelevant, actually.
Okay, sir. Okay, sir.
We shouldn't worry about those small little dots here and there,
right,
because
sir.
that is a sign of reperfusion. And if there is no drop in the NIHSS, and if it's not a blob, like a parenchymal hemorrhage, don't worry about it.
Right.
This is seen very, very often, and it has. The clinical significance is that reperfusion has occurred, but it doesn't produce any problem. People get worried. Oh, there's a hemorrhage in the brain. Actually, it is irrelevant. So don't. Right. This is for the juniors to understand that we don't need to worry about these things.
Right.
And there is that Heidelberg classification, if you know, of hemorrhagic infarct 1, hemorrhagic infarct 2, PH1, PH2. So where would you classify this?
Sir, I think it was class 1 only. Hemorrhagic infarct class
HI1.
Yes, sir.
So HI1, no need to worry. Rajshekar?
Yes, sir.
Absolutely. So I think HI1, HI2, PH1, PH2, all of us are familiar with. We must actually try to grade all these. So especially if you have students there, they must be asked to grade. And I think practically all infarcts will have some degree of hemorrhagic transformation.
Yes, sir.
And there's sometimes luxury perfusion also gets misinterpreted as HI1, because, and even as HI2, because relatively the tissue around that is looking a little more hyperdense as compared to the hypodense, infarct. So that is also something. Sometimes we put Hounsfield units and actually see, is this hemorrhage or is this just you ask the guy at the CT scanner to just do that, because sometimes one is afraid and then you hold off the antiplatelets for a few days thinking that, this might get worse and things like that. The other thing that we need to remember of note here is that it's likely that embolic infarcts are more likely to have a hemorrhagic transformation. So we would probably in such a situation be very aggressive in trying to look for any kind of cardioembolic source. We've already probably done CT angios a little later and seen nothing there. Then I would probably want to be a little more aggressive, make sure the Holter is done, make sure no cardioembolic source. So this is a very kind of infarct that you see seems to be something that has emanated from the heart. So that's another thing that you must remember.
Yes. Yes, Dr. Mendinata?
Yeah, I will blindly endorse what Nasli said. Why blindly? Because it's so well known that there are 3 types of infarcts after ischemic stroke. The first are like white or pale infarct. Second type are mixed infarct. Mixed infarct are the commonest, where some blood can be, which is called hemorrhagic transformation or hemorrhagic infarct. One is pure hemorrhagic infarct, that is called red infarct. So commonest are the one which are mixed infarcts, which you had. Now, if suppose tenecteplase was not given, even then in a natural process, when you do 24 hours later, you may say, find some punctate hemorrhages, which my colleague, dear colleague, Nasli has mentioned, and rightly so. So nothing to worry, and most of these asymptomatic. Can I ask you, Divya, I'm hopeful you gave around 15 milligram of tenecteplase to this gentleman. He looked around 70 kg from
sir, he was a bit low weight. He was 65 kgs of weight, and we gave him 13.
Okay.
Yes, sir.
13. Okay. So you said 0.2 milligram per kilogram body weight.
Yes, sir.
Okay.
Yeah. There's a little confusion on how much dose one should give. So I think the label says 0.2, but most people in the world now are giving 0.25.
Absolutely. That's what I was going to say. Yeah. With a ceiling of 20 milligram.
This Nortest trial, which was done in Norway, they were giving 0.4. But then, they had a little more hemorrhages. So I think that is now given up. And most of the world is using 0.25. I think there's general consensus on that. And it seems to work pretty well. And there is no excessive bleeding. It's the same as anything else. So I think we should stick to 0.25. Though the label says 0.2. Isn't that correct? Is that correct? Yeah. Okay. Now, how do you explain all those, constructional apraxia and whatever? How do you explain with that anteriorly situated lesion?
Sir, probably at that time of acute lesion, there might be some perilesional edema affecting the parietal lobe too and extending to that territory, or might be some subcortical fibers, they get affected during that course and finally revive after thrombolysis. So we can say that in the acute stage because of the
penumbra?
Yes, sir, penumbra zone basically.
You think that was the penumbra which has now reversed?
It might have been salvaged by the thrombolysis, but I cannot go for surety, sir, because I didn't perform the perfusion image. But I think it might be the penumbra.
It's an assumption. I mean, we haven't done that, and not many people do it.
Yes, sir.
And it's actually not necessary. So no, I'm just talking theoretically that and all those tests you did, how many hours after the stroke?
Sir, the MRI was performed
No,
like
not
2 hours.
MRI. All those construction tests and clock drawing tests and all that.
That was like for the first hour after thrombolysis, we monitored him extensively. And when we found him stable, then we started conducting these tests, probably 1 hour after thrombolysis, sir.
1 hour after. Okay.
I think, Divya, that's too early to do these. These are a good exercise for the residents. You have set an example. But obviously, it has to be first is emergency management. Let the patient settle down. And then, as we say, penumbra. Earlier, when we didn't have these CT perfusion, we didn't know about penumbra. But even if you give a case to the residents, so usually it will be given after 72 hours or 6 hours later to do these activities. So it's better to give some cooling period. Yeah.
This can produce stress and high BP also.
Yes, sir.
So,
got your point, sir.
And we are worried about, BP. We are very worried about BP in the acute phase. So do all these, sophisticated tests, so-called. Little later, aram se you can do, no problem. It's not going to change. First, you have to treat.
Yes, sir.
You have to treat. You have to shoot. You can't make long diagnosis in stroke. You have to make early diagnosis. You have to make a diagnosis first few minutes, 2 minutes, 3 minutes. So we shouldn't give the message that do all these constructional tests in the beginning. No. In the NIHS, there are a few things, that you have to do. But that's about it. You don't have to do these detailed examination in the early stage. Do it later. No problem. It's a good teaching exercise, and you have shown it very beautifully. The clock drawing was really outstandingly shown. So we really love that. But I think you do that after, as Dr. Mendinata said, do it later. No issue.
Right, sir.
Yeah. And what Dr. Rajsekhar said, you must look for cardioembolic stroke. This type of lesion, you must do a Holter, you must do a good echo, maybe even a TE. Have a very low threshold for doing TE, especially in young people. You never know what clots you pick up. Past myocardial infarction, LA thrombus, PFO, aortic sometimes plaque. So, have a very, very low threshold for doing TE. Transthoracic Doppler, of course, you must do. But for TE also, you should have a very low threshold. Do you agree, Dr. Rajsekhar?
Absolutely, sir. I think that's very valid point. If you think that we're not being able to find in some situations, because conventionally, though the cardiologists don't seem to agree with us, they feel that the transthoracic echo is sufficient. But we know that transesophageal echo has a pickup rate of 93% as compared to 60 to 65% of a transthoracic for a LV clot, etc. So it's always, if you have high suspicion, just go ahead and do it, because it's treatment changing. You're actually going to be putting a patient on anticoagulation, etc. So that's important.
Nasri, can I make a point?
Yes, sir. Yes, sir.
I have published one paper of 85 subjects of stroke with cardioembolic stroke, right? These were primarily in the posterior circulation. If there was a stroke like this in posterior, and definitely you have to rule out cardioembolic. And in this gentleman, if there are not many risk factors, the CT angio is clean, and the infarct or stroke is in the lobar area. It's a superficial or cortical infarct. In those, you must look for cardioembolic, as my colleagues are saying. I will go even beyond. When I came to BLK Max, there were not many TE being done. Now it is being regularly done, because I'm fond of stroke in young, so we are getting in everything. I've gone one step beyond now. Even cardiac MRI is more sensitive and superior compared to TE, because TE is invasive, it is uncomfortable, and many cardiologists are not willing to do TE, or they say. But cardiac MRI, if patient can hold breath for 1 second, cardiac MRI is far superior. And we have also included one article in our puzzling cases in stroke recently, that silence is not always golden. What Rajshekhar said, what was there is strophenia, no clue from where it is coming. When we did T, there was a myxoma sitting in that child, and we got it operated and everything became better. So all that must be looked into.
Point well taken. I think we are not using cardiac MRI as much as we should. So, what you have done, I think, is pioneering in a way. And we must use it more and more. Now we have good 3 Tesla MRIs. So we should use them. Surprising things you find, I remember one case, somebody had published, they found one schistosomia in the cardiac MRI and that embolized into the brain. So this is unheard of. I mean, I had never heard of it. So you'll be surprised what things you find, So do it. If you are able to do it, do it. And you'll be surprised how many new things you will find.
But Nasli, still in our country, I am not saying about the main institutes, radiologists are also reluctant or they don't have enough experience.
Yeah.
I sent 3 persons for cardiac MRI. Every time they said the patient didn't cooperate, which I can't digest. So there must be some reason.
आपका हाउसमैन भेजो उनके साथ.
I will go myself. Nasli, if I have to go, I'll go myself with you.
So, these things can give you lots of information, even long-term Holters. You'll be surprised how many times you see. And, seeing LSIs, doing pro-BNP, seeing for atriopathy, these are all, and as Rajshekhar said, it changes the treatment because now you have to give anticoagulant instead of antiplatelet. So it's changing. I mean, it changes the treatment. It changes the prognosis. So look more and more into and try to find what we call mechanism of stroke. Every patient, you must write at the end of your notes, what is the mechanism of stroke, MOS. Sometimes you can find it and sometimes you can't, but make an effort. Rajshekhar, you want to say something?
I think we're good, sir. I think very good. And again, Dr. Divya has kept up the very high standards of this meeting. Every time I'm so impressed by the kind of work that is going on. It's a pleasure to know all these people doing fabulous work everywhere, sir.
Yeah. So it was a
one thing I want to add. Yeah, I want to add for Holter. Now, new guidelines are that they should be done at least for 3 days. Now we know about external loop recorder, internal loop recorder. The other aspect is economics. 24 hours Holter is now as economical as 1 MRI or less than 1 MRI. So there are agencies which are doing very high standard Holter and around 4,000 rupees for 24 hours.
7-day Holter is 5,000.
Yeah, so now it has become so reasonable. We may pick up more cases.
Do more, Yeah. So very, very nice case, Dr. Divya, and thank you for a wonderful presentation. And we are really delighted that you are doing such good work and you've been able to reduce your door-to-needle time to 20 minutes. From 4 hours to so that's excellent. And keep it up. And now bring it down to 15 minutes. And you'll see what great things happen when you bring it down to 15 minutes.
Thank you.
So well done and congrats.
Thank you, sir.
Next meeting in Divya's place.
Huh?
Next meeting in Divya's place.
No problem, sir. Anytime.
Sir, with your permission, just wanted to comment. So we are almost halfway through our episode, and we have approximately 200 logins, or rather live listeners now. We have multiple comments which are congratulating Divya ma'am for her case in the comment box. However, there's no more questions there. So I would now, with your permission, sir, invite our second speaker, Dr. Sanjay sir, for his presentation.
Yes, Dr. Sanjay.
So on his behalf, I would be presenting his slides. Sanjay sir, with your permission, you can start.
Yeah, sure. Thank you, Sanket. Good evening. It was a wonderful academic discussion, basically. Though the case was very simple and all, but we had a very good academic discussion on that case. Now I will present this case. This one is simple, very simple. As like last case, there is no much academic discussion as such, but it's a very interesting case.
We'll find some
A male
academic
patient of
discussion.
70 years old. Sir,
Sorry. Continue.
hello.
Yeah, continue. Sorry.
A male, okay, a 70-year male patient was a known hypertensive since 5 years on dual antihypertensive medications like telmisartan and hydrochlorothiazide. His blood pressure was controlled with these two medications, and he's a diabetic since last 5 years, which is controlled on insulin and oral hypoglycemic agents. And along with that, he was also dyslipidemic according to his old records, and he was on statins, and his lipid levels were within normal limits now. And he had no history of cerebrovascular accident in the past, like TIA also, and no history of coronary artery disease in the past. But this 70-year-old man is having a very high vascular risk factors, such as hypertension, diabetes, dyslipidemia. Almost all common vascular risk factors are present in this person. Next slide. So he presented in the ER with a history of weakness of left upper limb and left lower limb. So he had left hemiplegia and associated with slurring of the speech. When he presented in the ER, it was only of 1 hour duration. And immediately we recorded his blood pressure, which was 150/90. He has taken his routine antihypertensive dosage. And this thing on after examination, we found that his NIHS score was 11, in which there was a dysarthria, 1 score. He had a facial deviation. For that, we given 2 points. And he had a complete power 0/5 in left upper limb and left lower limb. So that score became total 8 + 2 + 1, NIHS score 11. So it was like a moderate stroke. So with this, we immediately, as it was like 1 hour duration, we immediately shifted that patient to MRI. So this MRI scan showed very large diffusion restriction on the right side. Almost complete right MCA territory was involved. And that was associated or corresponding ADC suppression was also there. So it was complete right MCA infarct was there. Next slide. So with this such a large infarct, the flare was also done, which was showing no lesion on the flare. So nothing was seen on the flare. So there was a huge diffusion flare mismatch was there. So immediately in the same setting, we did MR angio also. Next slide. So this is complete M2 obstruction is there. So it is a large vessel occlusion on right side, right MCA M2 segment was complete cutoff. Next slide also you can see that complete cutoff. Yeah. So it looks like a M1 segment, but M2 segment is completely cut off on the right side. And it is showing that it is a very large size infarct. Meanwhile, after shifting, coming out of the MRI, we had that biochemical test available. Next slide. His platelet count was normal. Sugar levels were 178. Serum electrolytes were normal. Creatinine normal. All coagulation profile PTINR also we did. It was normal. So it took almost half an hour for MRI. Previous slide. We did like MRI and these lab investigations. Now we came to conclusion that he was having a large vessel occlusion, which was leading large right-sided MCA infarct, in which there was a diffusion flare mismatch was there. And this was like 1 hour, and all this test took almost 30 minutes. So it was like a 1.5 hour duration. So the question was now, it was like a M2 segment was occluded, very large diffusion restriction is there. So we are confused now what is to be done. Whether to shift the patient directly to mechanical thrombectomy. But in our center, mechanical thrombectomy, that facility is not available. Then next option was, next and first is obvious is IV thrombolysis. Then I discussed with the patient attendants, because this is a large size, more than 2/3 of MCA involvement is there. So we explained all the hemorrhagic transformation risk, then it may be mass effect, and all those risks were explained. All contraindications for the IV thrombolysis were ruled out. This was a very tricky situation as time duration was less, flare was absolutely normal, but lesion was more than 2/3. So this thing little confused also whether to thrombolize or not, whether to send to the higher center directly for mechanical thrombectomy. But the relatives were also willing, because from my place to send to the Hyderabad, it takes almost 4 to 4.5 hours. By the time that infarcts will be settled down and all those things, so they were agreed, go ahead, sir, with IV thrombolysis. Then within a time of 5 to 10 minutes of counseling and all, we immediately thrombolized with, next slide, 0.25 milligram per kg body weight tenectase we used. Almost his weight was 60 kg. So 15 milligram injection was given, bolus over a period of 1 minute. Then to my surprise, his power started improving over a period of 15 to 20 minutes, next 15 to 20 minutes. And at the end of 1 hour, his NIHS became only 1. He had only dysarthria. His power improved completely, almost 4+/5 in both upper limb and lower limb. Facial deviation disappeared. And the only thing remaining was dysarthria. He had only slurred speech. And after 1 hour, he started walking without support. Next slide. So this was after 2 hours, we did again this thing for academic purpose only I did, because patient had complete recovery. But again, MR angio was done, which showed that M2 segment was completely recanalized. There was MRI angio was completely normal, and patient improved very well, started walking. So it was like a miracle for me, because this was a case for mechanical thrombectomy, but it got recanalized completely with 0.25 milligram of per kg body of tenectase. Next video is there. She started walking without support. Actually, previous that power zero video I not recorded that time actually. And another thing I missed is MRI brain after 2 hours. That diffusion, whatever that restriction was there, it was restricted only to the insular cortex. All the diffusion restriction, whatever more than 2/3 territory was there, it disappeared within 2 hours only. Thank you.
Absolutely wonderful.
Thank you, sir.
This is called VENI, very early neurological improvement. This occurs in about, I don't know how many percent, 15%
to 20%. 15 to 20%. Yes.
Yeah, 15 to 20%. But there are certain points I think which we need to talk about in your presentation. First is, if he has come within 1 hour, you don't need to see diffusion flare mismatch. See, that is for wake-up stroke, and that is for stroke of unknown time onset. For acute stroke coming within 1 hour, there is no point in doing flare, this, that, and wasting time. See, time is of the essence.
Yes, sir. Actually, the patients in our area, they are illiterate, sir. Most of the time, they don't know onset of the deficit, because they will keep on telling 1 hour, 2 hours, 3 hours like that. But we cannot believe that exact onset of duration in our patients, sir. Because most of the times what they say, they will tell 2 hours means, no, sir, only 1 hour. He called me 15 minutes back only, it was normal.
See, if it is less than 4.5 hours, you don't need to do it. When it is wake-up stroke or unknown time, if it is 1 hour or 1.5 hours or 2 hours, no, you don't need to do it. And you don't need to make a judgment on it. And now I think most of us are agreeing that you should give IV thrombolysis prior to mechanical thrombectomy, unless there is a contraindication, like say platelet count is low, or there's some bleeding tendency, where you would do direct mechanical thrombectomy, or you can shift the patient immediately to the cath lab within the next 5 minutes. 5 minutes. Otherwise, in your case, it is like a drip and shift situation.
Yes.
In a drip and shift situation, IV thrombolysis has to be done, and you'll be surprised 25 to 30 to 40% of patients recanalize even in the MCA. So it is not a must that you must do mechanical thrombectomy in all these patients. In our resource poor settings, I am convinced in my mind that you should do IV thrombolysis in M1 and M2 and even distal carotid. You'll be surprised that 25 to 30% of patients will recanalize, and you will get an amazing result like you did. And the patient will be so happy with you.
Yes.
He'll be your friend for the rest of your life and his life. So don't deny the patient this treatment, and don't think too much. Don't think too much. And even this thing of large diffusion, that criteria is now given up. Low aspect score. Low aspect score also you can do IV thrombolysis if he's come in the window period. So don't rely on that so much. Dr. Mendinata,
first of all, congratulations. Excellent case, excellent results. I will say very lucky doctor and the patient. Everything went in the right direction. So these are the things which increase our practice. As he said, he will be your friend for lifelong. It was. I think I agree with Nasli what he said, that we have to do this mismatch and other things if there is a indecisive period of occurrence. And in these patients, I think it's not you have asked for flare, but computer takes the sections and that it collates and gives different pictures. So it comes naturally. Radiologists will say, no, I will do it. I'll do it. It will be there in the report. But definitely in wake-up stroke and not certain time of occurrence, definitely we should do. And in this patient, he is a high-risk case, definitely. Diabetes mellitus, hypertension, age. We don't know about family history. But if you see his MRI, especially the flare image, there's a leukoencephalopathy, bilateral diffuse white matter changes with some microbleeds. So he's the candidate where we have to give prophylactic treatment for the rest of the life, and very aggressive because he's diabetic and hypertensive. So we'll come to that later. What did you start him for secondary prevention after that hot period is over? And the other observation which I made, though this was MRA and not CT angio, that in MRA, maybe he has diabetic nephropathy. He will have, because diabetes is long-standing. So creatinine may be high, so CT may not have been done. But in this, if you look carefully, analyze images, there's also evidence of intracranial arterial disease on those images, what I saw. So this patient needs for further prevention. And at 70, he is quite good. But when he was walking, if you carefully see that his hand was slightly abducted and the dexterity was not as good as on the right side. So that dexterity is still left, residue is left. And you must also look for cardioembolic component because there is a sudden cutoff. There is nothing in the neck. And this, I have given presentation where I always say, aorta says, please don't forget me. So we must look at aorta and as well as cardiac component, as Dr. Rajshekhar has emphasized in the previous case. So in these, further workup is required, and further strong preventive measures are to be taken because he is diabetic also. The strategy will be different in hypertensive versus diabetic and hypertensive. So I will ask you, what did you start later on antiplatelet drug? Single or dual?
Dual, sir. I started on dual antiplatelets and started off 80 milligram atorvastatin.
After how much time? After how much time of thrombolysis? After how many days?
24 hours we started, sir. 24 hours.
Okay, and the check CT didn't show any hemorrhage.
No hemorrhage, sir. Nothing. Only that insular
Okay,
cortex part was.
Yeah. Rajshekhar, I think you are making a point. Rajshekhar, please.
No, sir. I think that was again a very good case. But two things that I want to emphasize here. One is when we are worrying about the size of the infarct. Unfortunately, when you do it very early, invariably MRIs will tend to show a larger stroke. So this, obviously, if you've done a CT scan, you may not have been so frightened. So one is, of course, the learning points that might come across in such a situation is we must also be able to recognize early CT scan signs of a large stroke. And maybe because this is so early, when you did a CT, if you had done a CT scan, you would not have seen the early changes and you would have thrombolized and the patient would have done fine. I'm trying to say that our worry came about because the MRI was done and we see this large area which is at risk of infarction on the diffusion weighted image. And like Dr. Ichapuria said, that by and large we're looking at diffusion versus flare mismatches in patients with stroke of unknown symptom onset, so SUSO or what is called a wake up SUSO or a wake up non-SUSO and all that stuff. Now the pros of diffusion flare mismatch, largest trials have been done for intravenous thrombolysis trial, and there's not that much evidence for endovascular if you look at a diffusion flare. I mean, there are three things that we're looking at. We're looking at time of onset, we're looking at size of core and size of penumbra. Three things that you look at. And diffusion flare mismatch is easy after, for me, it's always CT head with a CT angio neck and brain vessel. But suppose I had to do an MRI, I would choose flare diffusion mismatch because it's easier than perfusion imaging. You're not using contrast. There's also, at the end of the day, sometimes one of the cons of diffusion flare mismatch is that sometimes you will miss patients if you get scared who will benefit from IVT in spite of the fact, like this patient, for instance, you're worried that, if you give him IVT, he may not improve with proximal M1 or proximal M2 or, distal IC or IC occlusion. And like Sir said, when you give them IV thrombolysis, they do get better. So I think the learning here is two things. One, if I know we prefer to do CT scans, that's my way of looking at things. If you have some quick sequences of MRI, which you have sort of standardized in your center, you can do that. You can do a quick, let's say a flare, you can do a diffusion and a GRE sequence just to get basic information. And when you thrombolize these patients, like we've seen, IV thrombolysis, even in patients with large vessel occlusion, especially so with tenecteplase plays, there have been very good results. So that's also a good learning point from this case.
Yeah.
I will make one more point that if you are swinging between 4th and 5th hour, whatever the scientific guidelines are, at that time mismatch, like suppose you think it's 4.5 hours just crossed. There's nothing like 4 hours 31 minutes or 4 hours 32 minutes. So if you are swinging between that time definitely mismatch may be of help. That if you plan that you may have to go for the mechanical thrombectomy. I always say when these thrombolysis to be done, we should count in minutes and not hours if possible, that to save each and every minute. So what Rajshekhar said, right, that mismatch may be important in addition to what Professor Nasli said, that we may have to do mismatch study if we are at the border zone of time. Do you agree, Rajshekhar?
Absolutely. So I think, like you said, the greatest value is when we do not know stroke of unknown symptom onset or a wake-up stroke. This is where we would want to use a diffusion flare mismatch. And, unfortunately, there are not a lot of stroke studies where MRI has been used as the initial modality. So how much actually these diffusion things change is not well sort of, at the moment known, because let's say if you have 100 strokes who come in within 1 hour and they all have MRIs, we may see diffusion restriction in a large amount of them. And then, you thrombolize them and you don't see very much later because it's completely recanalized. The diffusion change completely reverses. So, but most of our studies would have CT at that point of time. So when I say that, I mean, if we have a larger number of studies with early MRI, then we may see this more frequently, the kind of picture that he's showing us. It's not a very common thing to do. That's the thing. And I understand that there are now people using MR sequences, but one of the learnings from this is also that if you see a large change on MRI early, you should not get too worried. Especially
not get scared. Not get scared, yeah.
Not get scared.
Yeah.
And I will also like that when I joined BLK Max, it's just 1 year and 5.5 months, we were on MRI protocol. And one day we had a meeting, how can we save time further because less of thrombolysis has been done. So then we have shifted to CT protocol, as rightly Rajshekhar has mentioned. We have shifted back to CT protocol now, and CT and CT angio are done almost simultaneously. Thank you.
Yeah, and one point, which I found very interesting, and we've been seeing it off and on, but not, as Rajshekhar said, not well documented, is that the diffusion goes down. We always thought that the diffusion is something permanent. It's not. Absolutely. There is an area, Sanjay, you have a scan afterwards, the MRI?
Yes, sir. We did, only insular cortex was involved, sir.
So that diffusion which was so big has now shrunk. So, it's not a permanent thing. Yeah. So therefore, we are saying that, the aspect score is high. I mean, it's low. It's not so, because the diffusion does change over a period of time. So don't get worried with these large diffusion lesions and, not to give thrombolysis for these patients. I think it's wrong practice. If the patient is in the window, if his NIHSS is correct and there are no contraindications, don't worry too much about these diffusion things. Thrombolyze these patients, give them the benefit of the treatment. Do not deny. Do not find an excuse to deny treatment. Find a reason to give. I always say this. Find a reason to give and not an excuse not to give. Especially when he's in the time window, which is now standardized, which has been proved, so many thousands of patients, lakhs of patients. So don't deny patients just because, the diffusion is little big and this is little big and all. Don't deny. I think that's wrong practice. Would you agree with me, Dr. Manmohan? And
yeah. Sanjay, can you make your phone in the landscape format? You will be well like us. You will agree. Look at that. Now you are much better. Okay. So what that reversal of diffusion are the reversible changes in the cells, hemodynamic changes, and these cells are still alive. These are not the dead cells. So the apoptosis has still not happened. So if you do this, as he rightly said, canalize, they are like sort of crying for blood. Give us some perfusion, please, through thrombolysis. So once that perfusions come, the cells come back to their life. So that's very important point. And in the end, I have the opportunity to work with Professor Vardan Hake in Heidelberg when I had gone for WHO fellowship. And I assure you people, and that's what I've seen I'm telling from my experience, maybe in the coming years, window will further get prolonged. If you go into Boyd's pathology or Robin's pathology, molecular death sets in 12 hours. 12 hours. So still, though there is a cell which may not reverse completely, there may be still window period of 6 hours, or maybe sometime up to 9 hours it may come in the coming years. Now look at mechanical thrombectomy, how the window has been increased to 24 hours. So same for thrombolysis. I am confident. You will say, sir, why don't you do a study? Why don't you prove it? You are in a government institute, you should have done, but not easy to do. But I am confident, that is my hypothesis, that in the coming years, this window period will further increase.
It's already increased to 9 hours, Dr. Mendinata. It's already increased to 9 hours, in carefully selected patients, of course.
Yes, carefully
not across
selected.
The board.
Not
but
all.
In carefully selected patients, IVT up to 9 hours, it's come. and is going to come. What you are predicting is going to happen.
Look at wake-up strokes or this. Sometimes this may be 9 hours. You never know.
Yeah.
Yeah.
So, Dr. Sanjay, another one point you mentioned that you did all those tests and then you give thrombolysis. Did you do that?
Sir. Yes, sir.
Platelet count and whatever the other things.
Yes, sir. When patient arrived at ER, we immediately send the lab investigation first, sir.
You can send, but you don't need to wait.
We are not within that till the MRI get finished.
No,
or counseling and all.
You don't need to wait.
What he is saying is we used to wait.
Don't wait for the report to come. You can
there was a time.
No, we were not waiting, sir. By the time we were not compulsorily, we were not waiting. By the time MR finishes and we do counseling and all.
Counseling
you
takes
mentioned
5 minutes.
You mentioned half an hour, 1 hour MRI, half an hour test, and then we went.
What I want to say, I don't want to give this message to everyone. The message to everyone would be that do the labs, but don't wait for the results to give thrombolysis. Especially what you're interested in. Of course, blood sugar, you have to do immediately. The oxygen level you have to do immediately. I mean, it takes 30 seconds to do that. Only problem is the platelet count. Now, if the person does not have dengue or does not have chemotherapy or liver disease or splenomegaly, there's very low chance that he will have platelet count below 1 lakh. So you don't need to worry. You just look at these small little things here and there. And if they are, you don't wait for the report. You send the blood, but don't wait for PT-INR if he's not on warfarin, PT-TK, you're waiting. No need to do that. Yeah.
Yes, sir.
No, I just wanted to make that point because that was a little unclear in your presentation. So I just wanted to make sure that everyone understands that. I mean, it's no reflection on what you did, but I'm just trying to make it clear to everyone.
Sir.
Yeah. Dr. Manmohan, I think you will be the best person to sum up the meeting today.
Oh, thank you so much. That's a great privilege I have been given. So I am the first time in the team, and I've given a chance to open and close the inning. That's so nice of you, Nasli. I appreciate that. So we had 2 cases which were very interesting. And Dr. Divya presented a case of ischemic stroke. They say as soon as patient comes in emergency room, you should do a quick workup, including vitals, and quick workup to see if there is no mimics or there are no chameleons. Once we have done that, the therapeutic should not be delayed if the patient is comfortable and suitable for thrombolysis. Now that case, in addition, she did some, we asked the residents to do lobar function, and that was really very impressive. The message was that definitely if you have MRI, fine, otherwise CT, and 1 or 2 spots here in the infarct zone, doesn't matter if there are hemorrhages. Even in NINDS, it was known that there were 6.4% chances of hemorrhage, but only 0.6% was symptomatic. So asymptomatic hemorrhages are quite common. That should be the message we should go. And we should encourage more and more physicians and people who are the first recipient of the case to practice polysis. They can be trained. And especially with connective players, life has become so easy. So easy. Even when the consultant is not reaching the emergency room, they will tell the resident, start this quickly. I'm coming. That's what we are doing. Now, second case by Dr. Sanjay, again was MCA infarct, but he has to do something different. So it was on the opposite side what Divya presented. It was on the right side. So that was, Divya case was left side. This was right side MCA infarct with the left hemiparesis with dysarthria and facial weakness. And that also very early it has been done. Door to needle time was quick, if not the fastest. And the response was very rewarding, very, very rewarding. But in both the cases, as my colleague said, Nasli and Rajshekhar, that we also need to do a good workup. Still, you may end up as SS. You never know. Still, you may end up as SS if, like, carotids were clean and cardiac cause should be ruled out carefully. And in your case, it was a young person, I think. So APLA and other hemophilias, thrombophilia should also be ruled out. Sorry, not hemophilia, thrombophilia should be ruled out. But that's only after the routine test done, scanning not only vessel, but aorta, cardiac chambers, etc. up to the ascending and arch of aorta. That must be fully done. When you are assessing a case of stroke, except with the acute management, prevention is very important. Not only medical management, but also rehabilitation is very important. And the most important is never forget also to look at target organ involvement. The patient who is diabetic and hypertensive, diabetes and hypertension is for whole body, not for heart and brain only. So in those situations, you must carefully look for eye, you must carefully look for kidneys and the peripheral vessels. So there should be a comprehensive workup. And though the thrombolysis is very rewarding, but we need to be responsible for the prevention of these type of episodes in the patient and prevention of other complications which can arise as a result of a number of risk factors. And I once again congratulate both the presenters, wonderfully conducted by the course director, beautiful comments given by Dr. Rajshekhar Reddy, and educational support from Emcure, which is always on the forefront for the academic activities. I think, Nasli, with this, I'll say a big thanks to everyone, and final word will be from your side.
Thank you, Dr. Mendinata. Very well summed up, as usual. I think Rajshekhar will also agree that we've had a wonderful discussion, and we discussed so many points. And I think it is very educative for everyone, including all of us. And we must thank Dr. Sanket and Emcure for getting this program together and reaching out to so many hundreds of neurologists all over the country. And I'm sure they will benefit a lot by these discussions. At least we hope that they benefit. So thank you once again very much. And back to you, Dr. Sanket.
Thank you, sir. Thank you, sir. Firstly, I would like to say that it's been this is the third meeting that we're doing, and being on the virtual platform, most of the companies or most of the hosts like me would say that there are so many logins. However, I would like to corroborate saying that in those logins, we have so many good comments from most of the participants, mentioning about the flow, mentioning about the discussion, mentioning about the way we are conducting this event, which is I would say, which is more of content and the rich content that flows in this meeting rather than any other specific discussions. So also, sir, thank you, our course director, Dr. Nasli, sir, for being there and giving your expert comments. I would also want to thank Dr. Reddy, sir, who had been there from our first meeting and has been an expert, in terms of, I would say, the jugalbandi that you have between the course director and you. I think it's fabulous. I especially want to thank Dr. Mendinata, sir, for being present for today's event. Sir has given us evidence-based, research-oriented discussion, and each case was so excellently taken into those nitty-gritties, and the listeners would get something which probably tomorrow they would imbibe in their practice and get better patient outcomes. And lastly, sir, this meeting wouldn't have been possible without our case presenters, Dr. Divya ma'am, as well as Dr. Sanjay sir, who has presented us excellent cases. And just a recap of what happened last time, sir. Just if you also would remember, last time the two case presenters was actually taking vibe of each of you, and it was a discussion which was more of a question answer kind of a session. again a different pattern which had in the last meeting. This meeting was unique in its own way. So I want to thank each and every one of you. And from Emcure, from the house of Emcure, I want to thank each and every one of you participating excellently today, and all the audience listening to us and have gained insights from this meeting. We will see again next month, same probably date and time. Thank you all.
I hope we pass the last viva, huh? Okay. Bye everyone. Thank you.
Thank you everyone.
Bye.
Now see the match. The match is pretty interesting, I believe.
Good night.
Yeah, 200